infectious diseases, research, medicine, health. Welcome to Outbreak News Interviews. And now, broadcasting from the Outbreak News Skylar Studios in beautiful West Central Florida, here is your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Well, hey everybody, this is Robert, and welcome to Outbreak News Interviews. Now, President-elect Joe Biden recently announced a new 13-member COVID-19 advisory board to guide his administration during the transition period. Now, one of the 13 is the Center for Infectious Disease Research and Policy, or CIDRAP, Director Michael Osterholm, PhD. And Dr. Osterholm has been a guest on this show numerous times over recent years. Dr. Osterholm, welcome back to the show, sir.
Robert, it's good to be back with you.
Now, let's start with your appointment to the President-elect's COVID-19 Advisory Board for the transition. Congratulations. What is the board's role, and what has been done so far with the current COVID-19 team led by Vice President Mike Pence?
Well, first of all, I can't speak for the transition team itself. There is a group of experts within the transition team that is working with the administration, the current administration, to interface and have a handoff there. I can just say that having been a member now for several weeks of this advisory board, I'm very impressed with the emphasis that the Biden-Harris administration will place on science. And I think that that's been something that's very important in terms of how we make decisions, how we place our priorities in terms of disease prevention and control. And so from that standpoint, I'm very pleased to be a part of this activity and help however I can.
Okay, great. So let's go ahead and talk about some issues that the public's confused about. There's some disagreement even amongst public health experts, and that's how to deal with the pandemic. And I want to go ahead and start with lockdowns. And in an interview last month, you brought up the idea of shutting down businesses in a lockdown that could last 4 to 6 weeks. Now, to many people, lockdowns don't make any sense. A lot of lives have been devastated by lockdowns. And even about 15 years ago, the renowned late epidemiologist D.A. Henderson rejected such a move. So, Dr. Osterholm, what is the evidence that lockdowns work or should be recommended?
Well, first of all, I think it's really important that we understand what are we talking about when we talk about lockdowns. If you ask 50 people what a lockdown is, you'll get 75 different answers. And in the interview that you're referring to was actually a discussion of a paper or an op-ed piece I had published with Neil Kashkari, the president of the Minneapolis Federal Reserve Bank, back in the New York Times in early August, talking about on a state-by-state basis, not a national lockdown, a state-by-state basis, the only way that we were ultimately going to gain control of this virus was similar to what we had seen done in the Asian countries, and particularly I have used Australia and New Zealand as examples as democracies. Well, everything that I had talked about is happening already. There are a whole series of actions being taken right now that in a sense are requiring people to distance. Some are calling these actually as lockdowns. I personally don't like that term. I wish we'd find another term, a pause, a distancing activity, whatever. But what we're trying to do is keep people from swapping air. And how do you keep people from doing that together? And why? And I think the second measure here is you're seeing many governors and mayors are in fact doing exactly what we just talked about right now because of the fact that our healthcare systems are overrun. We have a number of hospitals in this country right now that are literally on the verge of patient care collapse, where they're not going to be able to provide care to those coming to their front door. And this is the challenge we have, is how do we reduce those case numbers? So when you see, bars and restaurants being closed, and you see, public activities being reduced, etc., that's what we were all talking about. And, at the time that I had proposed looking at this, we were at 26,000 cases a day. Now we're at almost 200,000 cases a day, making it much harder. But so we are taking these actions, whatever you want to call them. Now, one of the things I added, though, and I have added from the beginning, is that we need to cover the cost of these activities, meaning that right now to cover for employees who've lost their jobs, small businesses who have been tremendously adversely impacted. From a financial standpoint, it should really be our role to help cover that cost, and that's what we proposed in the op-ed piece. So this isn't really anything new. It's what people often believe, where we just, shut every door, every window for 6 weeks. That's not at all. It's about driving the case numbers down so we don't have what's happening right now. Mind you that, 200,000 cases a day in our hospitals, with almost 100,000 patients today in our hospitals being cared for COVID. If these numbers increase by 20, 30, or 40%, of course, next season, there will be major challenges in our healthcare systems in this country, of likes we've not seen since 1918. And so I think that's what we're up against. So, when you weigh the cost versus what we're not doing, I think it all comes to play of, one, how do we protect our hospitals so that we can provide care, making sure that we have enough healthcare workers. Number two, how do we financially take care of people so that, in fact, the kind of pain and misery and, frankly, major mental health challenges that that this virus is inflicting on these people doesn't happen. And to me, that's what's really important right now. We're not having that discussion as a national discussion. Instead, we see 50 governors. We see many large city mayors all having to take it upon themselves to independently try to decide, if I shut down bars and restaurants, does that mean I can keep schools open? What does this mean? And that's the kind of discussion that we just need to have.
So you mentioned taking care of people that lost their jobs, closed their business and all that. Where does that money come from? Because the United States is broke. I mean, were we going to run the printing presses? No, actually, one of the things that we addressed in this op-ed piece was the fact that the national savings rate has gone up dramatically during the pandemic, from 8 to 20%. That money is sitting there right now waiting to be loaned to someone at the lowest interest rates in modern history. And the modeling work out of the economic world says that if you can keep business going, you can keep people employed, that financially, that is a much wiser use of that money, and we pay ourselves back for borrowing it from ourselves than just doing nothing. That's where the economic ruin is going to come from. That's where the economy is going to literally, take a major hit. And so this is way out of my league of qualifications and expertise, but the economists are saying this kind of investment right now is actually what will help save the economy and pay itself back, as opposed to trying to reconstruct our everyday lives after we go another 4, 5, or 6 months like this, and unemployment rates hit all-time highs. If small businesses bankruptcies go to all-time high, that's when the cost is really going to be significant. Okay, another issue that Mr. Biden has suggested is a national mask mandate. Are you on board with this?
Again, I don't speak for the Biden administration. I want to do whatever I can to minimize transmission between individuals. And I think the debate around the mandate gets to the point of who can do that work and it be done. And I think largely this is going to be a state level activity where if it's going to be enacted, it's the governors that are up to it. So, I can be for a mandate, but I don't have much authority on that if, in fact, it's all in the hands of the governors. And I think right now that really is the main point. But you surely can make it loud and clear that we think that, anything we can do right now, any layered effect we can do to minimize the transmission of the virus is what we ought to be doing. It shouldn't be political.
Right. Now, the CDC in 2017 said little evidence supports the use of face masks by well persons in community settings. So, Dr. Osterholm, what do we really know about the effectiveness of this mask mitigation? Because there's a lot of back and forth on that.
First of all, it's really important to distinguish between the kind of respiratory protection you're talking about. N95 respirators are highly efficient in protecting an individual. Surgical masks, which are not tight face fitting, have the next level of protection. And then, of course, face cloth coverings have the least. And the challenge we have is both as basically source reduction, meaning keeping me, if I'm infected, from spewing out the virus in my droplets or aerosols to someone else, or wearing it to protect me from someone else and keeping air that contains the virus from getting into my lungs. And those are two very different kinds of issues. At this point, it's clear that, there's variation in those three, with, again, the respirators being by far the most effective. There are data out there now suggesting that based on aerosol inhalation and movement, that some of the face cloth coverings may be 40 or 50% effective, potentially less than that. But I think the real message here is that we have a whole series of things that people can do. When I say don't swap air, distancing is critical. So if you wear a face cloth covering and you're going into a very close person environment, like a bar or a restaurant, you will have some protection potentially. And then, however, if you're there long enough, its infectious dose, as you know, is time of exposure and amount of the virus in that exposure air. And so, if you can reduce it by X, that's great. And I think right now that's an area that we need a lot more work on. It's just to understand, how effective these various kinds of respiratory protection really are. Mm-hmm. And at this point, I think those data are lacking in real definition, but there's enough there to say yes. Wear as another layer, just like if you put 10 pieces of Swiss cheese on top of each other on the table, you likely aren't going to be able to see the table itself. All the holes will get covered by one of the pieces.
Okay, Dr. Osterholm, another concern is COVID testing. And this really kind of came to light recently when Elon Musk tweeted about having 4 tests performed in one day with different results. So I guess my question is, how good or bad are the tests? And how do you convince the public they are worthwhile and accurate?
Well, first of all, you have to distinguish the kind of test. Now, PCR testing done with nasal swabs and to a very real degree, even with saliva, can be very, very sensitive and specific. That's important. And I think that we have to distinguish those from the testing done, what we call point-of-care tests. Mm-hmm. Those antigen tests, nucleic acid tests that are done with results back in minutes. Those tests are not nearly as sensitive or as specific. And so it depends on which test you get. And I think this has been one of the challenges we've had, is helping people understand a test is not just a test. So actually, I put a great deal of stock in PCR testing, particularly when, the nasal swab with the saliva is obtained in the correct manner. I have more concerns about the antigen tests that are done, point-of-care testing, and, how often they're falsely positive or falsely negative when, in fact, you either are the opposite. And so I think at this point, that's our big challenge.
Yeah. There's, of course, been a lot of great news about vaccines. There's no doubt about that. Any thoughts on that from you?
Yeah, I think the vaccine issue represents the best of times. It's just like, we're going through the worst of times right now. That's the best of times. It is light at the end of the tunnel. The challenge we have right now is getting us to those vaccines by minimizing the number of cases of infection before then. We keep saying, hold on, hold out. Do what you can to limit your contact with others that would result in transmission. This is our COVID year. This is not going to be like last year. It's not going to be like next year. With vaccines, we can make a big difference. So, during the first and second quarters of this next year, we're going to see, a lot of vaccine arriving in our communities. That's why you want to get your immunity, not through having to chance it by getting infected. And so to me, that's a really very positive development.
Okay, and let me close with this. There are some very high-profile public health people saying that even after the vaccines, we will still be wearing masks. So, Dr. Osterholm, what is the end game here?
Well, a lot of it, Robert, is going to be how well people take the vaccine and take it up and get vaccinated. That's going to be a huge part of it. Mm-hmm. If a very large segment of our society does, we can really beat the virus down to where it is a very low-risk situation. We, of course, want to continue to make sure that we're vaccinating in the low and middle-income countries so that those outbreaks and pandemic-related virus situations are addressed, because that'll, from an altruistic standpoint, we should do that, but also from a standpoint of the virus, blowing back into countries that have most people vaccinated, that will sure help. So we need a global response, number one. Number two is we need, our local and regional responses. If we only get 50% of the population vaccinated, we're going to have a real hard time with lots of additional cases occurring each and every month. If we get a much higher percentage than that, we could very well get to the point where we're not wearing masks anymore and feeling confident being in public spaces. And so I think it's all in our hands again with that, in terms of just how well vaccine uptake occurs. And that will tell us a lot over the next 6 to 12 months where we're going to go with this virus.
Very good. I want to thank you, Dr. Mike Osterholm, for sharing your time and your thoughts, sir. I appreciate it.
Sure. Thanks. Have a good day.
You too.